Alrighty. So going over Crisis, um, I'm kind of broke it down into the phases of Crisis, um, and kind of put down some like interventions, kind of the goals overall. You don't have to memorize the entire thing. You can kind of see from what is here is like a trigger, escalation, crisis, post-crisis, resolution. That's actually very similar to the assault cycle. um, that they went over in week 1, but the basic idea is still there. It's essentially the moment um, before you get to the crisis, and obviously you want to intervene before you get to that point, and just kind of the things that come before, the things that come after. So we'll go over that. I do have a thing that has like the different type of crises, but I don't think you have to memorize them. Maybe for the Kaplan, you might have these words come up for crises, and like it might ask you like what is going on in this scenario, like what is the thing that's exactly happening. But for the actual lecture portion, you don't really have to memorize it. But I just have it here just so that we can, instead of like memorizing it, it'd be like one of those things where we recognize it when we see it, or we can read it and be like, that makes sense based on based on that. After that, we'll go over human abuse, so general things, and again, not really for full-on memorization, but more for like recognition. And then child abuse, which again, for recognition. There's some things that you'll see come up more than others, and I'll go over also this homework assignment here. Just go through the answers on this homework assignment. Okay. Any questions on anything before we get going? Any questions on anything from previous previous days? Okay. So just going through the list here. So a crisis is going to be something that just disrupts your normal day to day. People, have coping skills, things that they use to kind of rationalize things or to make themselves feel better or be able to, well, cope with whatever stress is going on. Some people have an easier time than other people, have a stronger kind of like mental, but you'll see in the psych ward that a lot of people are less able to inhibit themselves, and they're more likely to have like big escalations leading to a crisis, which in which case, depending on how the staff is able to manage it, or depending on how severe their uh, their overall presentation is, might result in them, having to, if they're already in a locked facility, be given emergency medications, or like at Ocean View, they would be called a PET. So a clinician would come, evaluate them, and then they would get put on a hold if they meet the criteria. Okay. So starting with the initial, it would just be the triggers. Like, so there's something that causes someone to get stressed. It could be something as simple as they didn't get a nicotine break. They didn't get to smoke. They didn't get to um, get a snack. Literally anything like that. That could be something that would trigger someone to just decide that I want to hit someone or I want to bang my head on the wall, something like that. That could be, but that, that end result is going to be kind of further down the line here. But like whatever it is that causes stress, they'll use their whatever coping skills they have to try to kind of rearrange themselves. And at this point, your goal as the nurse is just to identify that they're having a trigger, try to redirect them, maybe you can offer them PRNs at this point, provide reassurance for them, maybe if you feel that's appropriate. But it could be something like, okay, well, I can just get the floor staff to get you a snack. I can get I can get you nicotine gum. Depending on how it is, sometimes you do have to set strict boundaries. So someone that missed smoke break or something like not every facility has smoke break, but like at Ocean View, we have smoke break, and if they miss one, a lot of the times it is just like, well, depending on how late it is after you missed it, it's just kind of have to be, you're just gonna have to wait for the next one, or I can get you some nicotine gum. And unless it's gonna be this whole thing and you don't and like nobody's busy, then we can take you down. But if not, it's just gonna be how it is. And you just have to set the boundaries there. And depending on the person, you might have to change that strategy up. Maybe you do give them the smoke break because otherwise they might go out of hand. It kind of just depends on knowing the patient and knowing what staff you have. Maybe if this is a person that could get really aggressive and is really big, very strong, you might want to reconsider depending on what your staff looks like. So depending on what your staff looks like, depending on the kind of support you have at the time, this kind of stuff might change like what you actually do. But going past the trigger and moving on to like what's called escalation, this would be when they're whatever coping skills they use for themselves, it's not working. Their anxiety is continuing to go up. They're starting to really escalate. So what do? You have to do de-escalation. So other than just kind of being redirection, maybe redirection, you can instead have some of that therapeutic communication. So some of the things that you can employ, and one of the most important things for you to do is kind of start with that emotional part of it. So the empathy and the restating of the facts. So like, it's like, you're upset because, you didn't get a snack and I'm sorry, or you don't even have to say I'm sorry. Sometimes it's better not to say I'm sorry because then it gives them something to kind of place their anger towards. You can even say something like, I hear you. It must be really upsetting to not get your snack, or it must have been really upsetting to not be able to get smoke break when it was time. You weren't woken up for it. And yeah, that must be really bad because that's something that you look forward to. It just kind of gives them something to like it gives them a way to kind of relate to you, or like a way to tell that you understand what's going on to some degree. So those would be the most important things. It's kind of like for people, like when your girlfriend or your wife, whatever, is angry, a lot of times they're not looking to be giving solutions, like logical solutions. They want the emotional aspect of it first. And sometimes just stating the logical part of it, like logical, maybe resolution of it, might actually upset them more. So in this case, starting with the feelings is like the number one thing that might help to de-aggro someone. Listening to what they're saying and being calm is another important thing, because being calm while they're kind of like escalating, they're yelling or starting to yell, or they're starting to just talk really fast and pressured speech, which is basically like they're speaking in such a aggressive manner because like and they're trying to get all the words out of their mouth and they can barely stop themselves from speaking. Uh, Having your level of tone and having your emotional regulation is important, because if you try to match their energy, a lot of the time they continue to escalate. But if you're calm, it's possible that they start to be calm with you because they again, they're still trying to do some coping skills here. They might be trying to incorporate new coping skills at this point. And you can also provide them with new coping skills at this point. But one of the things might be like, well, like everyone else around me is calm. Why am I the one that's upset? And that might be another way that they could de-escalate themselves. At this point, you can also try to offer PRNs. So some examples of some medications that might be offered here would be like hydroxyzine for anxiety, could be an Ativan, could be a cyprexacitis, which is an olanzapine, which is an antipsychotic that you can give. That one specifically is like under the tongue, so they give it under the tongue, and that one also helps with acute agitation, hallucinations, pretty much all that stuff. And olanzapine is also one of the ones that they do for an emergency shot. So, has anyone seen like David, you're at college, so have you seen them do like the emergency IMs or like a Cyprexa shot or a B52? They call it Benadryl, Ativan, Haldol. They also call it booty juice. Uh, Any seen any of that?
Um, no, like usually in the cold grays, they have us to the side, and I just
Hmm.
hear them do it, and like I've seen them draw it up or like get it out, but I've never actually seen them inject it.
Gotcha. That makes sense. Yeah, just get you out of danger, and that will also actually lead to the next point. So at this point now, they are not able to cope. Whatever you provided for them, they're not able to utilize, and then they reach the state of crisis. So now all coping skills have failed. Um, and at this point, they're now at a higher risk of either hurting themselves or hurting other people. So that is kind of your job now becomes very much keeping the safety around. So if there are other people out while this person is having their crisis, you're going to want to get them back into the room or just kind of reposition somewhere else. So in this case, you guys are students, so they actually just moved you somewhere else so that you were out of danger, essentially, or out of the way, so that this person can be a little bit more isolated and kind of reduce the amount of stimulation that's going on around them. At this point, this is where they might do restraints. They do like what's called a takedown. So they just hold them down in a safe way, potentially also give them an emergency injection. You would get an order for both of those. Get an order for restraints, get an order for the emergency IM shot. You don't need orders to do a takedown per se. But for restraints, like actual hard restraints to the bed or to like a chair or something, you do. So at this point, you want to be very clear and very firm. Something like, it's like, hey, I want to help you, but like, what can I do for you? Like, what is it that you need from me at this time? Something that could work is having them like directly state like what is it that needs to be done for you to feel better. Just the idea being that it gets them away from thinking about, being angry or being upset and gets them to kind of like their logic side of their brain because they're starting to think about maybe different things that need to be done, different steps that have to be done, or they're thinking logically about something. It kind of gets their mind off it for hopefully long enough that they calm down a little bit. But if not, that's kind of what you do. Your focus is on safety. Um, I've had a few instances where like a patient would be popping off. So I can give some examples there. There's one patient that was in a wheelchair. It was like a behavioral thing. So they were fine outside of the wheelchair, but in their mind they needed it. They got really upset with another patient, and this patient was manic, kind of just talking everybody's ear off, had like his own little clique. and they did not get along. They would he would go there and talk to him, but there would be times where the guy would just kind of insult him, call him like call him the R word, whatever. And it got to a point where he got so upset he almost got out of his wheelchair to try to hit him. Uh, we managed to stop him at that point. Just kind of had to talk to him like, because we're voluntary, we can't have that behavior here. If it continues, you're gonna have to go to college hospital and you're not gonna do well at college hospital. Just kind of have a very, very firm, genuine conversation about it. It's like, do you actually want to hurt him? Do you actually have thoughts of hurting him? Do you actually have intent of doing that? Do you have a way you want to do it? Because, if it comes down to it, we are gonna have to call the evaluator and you will be put on a hold and you don't want that. If it's actually in a locked unit, you're gonna do whatever you need to do to de-aggro someone and then maybe get the shot going, etc. But yeah, that's kind of how that kind of goes. After the crisis is dealt with, at this point, this is kind of when reality starts to set in. The patient might feel bad about it, actually. They might feel a little bit down. But at this point, they're willing to accept more support. And at this point, your job is just basically to maintain, help to retain their emotional control. Again, still safe, focused on safety, reinforce coping skills. And then the resolution part of it would be kind of like ways to prevent this from happening again. So this would be kind of like that talk with that one patient, be like, well, this is what's going to happen. This is what would happen if it were to continue to escalate. Here are some things that you can do so it doesn't happen again. Like, you know what, just walk away from him, right? You can be the bigger man, bigger person, and just walk away. If you're feeling bad, you can always come to us, get some PRNs, at this point, the patient was refusing his antipsychotic. So it's like, maybe we have to, be more consistent with it. Maybe based on this experience, maybe you want to give it a shot and see how that goes for you. Because again, you don't want to go to a locked facility because you're not going to do very well on it. You were there before. He was there before, and he didn't. It was like the worst experience of his life. So sometimes you do have to kind of manage all that stuff there. Going further down, this is like the different type of crises. Again, I would say don't hard memorize any of these. It would just be kind of like for recognition. You might get like maybe one or two questions or something like on the Kaplan about it, but I would not stress myself over memorizing these personally. But yeah, so some examples is dispositional. So it's some sort of stressor that's happening externally and it's situational, meaning that it's not doesn't come from you, comes from someone else, and it's something that doesn't happen all the time. It's a situational thing. So example here is like an abusive relationship. Next one would be anticipated life transition. This is based on something that is you can say it's expected, something that a lot of people go through, and something that's stressing you out. So becoming a father, becoming a mother, getting a new job, having that acute anxiety because of it, because of that change. Traumatic stress would be from an external stressor that is completely expected that you have no control over. So like a sexual assault, something like that, uh, would be something that's traumatic, something that could lead to like PTSD down the road. So that would be, something like that. Maybe experienced a car crash, been in a car crash, been assaulted, all that kind of stuff. And here's some other things that could be done. But we'll talk more about that with like the child abuse because, you know, all this stuff, or human abuse as well, all this stuff does happen there. So we'll go into more detail there. Maturation developmental crisis in response to failed attempt to master developmental task. So this would be kind of like not too dissimilar from the anticipated life transition. This is something like is anticipated, like, these are things that you set yourself to, but you might feel like you don't have full control over. Well, this one is specifically like you kind of failed at it, or you feel like you didn't master whatever it is that you're trying to master. Again, not something to memorize, it's just something that you can recognize. Psychopathic crisis would be something like based on a trigger due to a previous mental condition. So some sort of anxiety disorder, bipolar disorder, schizophrenia, and psychiatric emergencies. This one's to the point where they're so acutely impaired that it was literally to the point where could be like life or death, like almost life or death. They tried to kill themselves. They tried to hurt someone actively. Um, this could just be like being triggered by something like a snack, whatever. This is more like immediate harm to themselves, immediate harm to others. And overall, though, the main thing is that to you want to bring them back to that state of where they were before, or even hopefully were a little bit better than they were before because they got over this crisis and now they have new coping skills. They have better ways of knowing, better ways of understanding what not to do and what to do when things do kind of come down to it. Okay, now we're going to go down to human abuse. So these are things such as, um, you know, again, being hit, being sexually assaulted, or even just fear, invoking fear onto people. So some of the factors that can influence that would be, and this is kind of where you have like the stereotypical life, what was this? The stereotypical abusive partner who is insecure. So they hit their wife or they hit their partner because they it boosts their ego. It makes them feel better. It makes them feel powerful above someone. So that would be like the general rationale. So, that's like the most common one. Other things that could cause abuse would just be kind of like that cycle of abuse. The children imitate their role models. So like their parents were abusive, it's more likely that they will be abusive when they have children or just towards other people. Other things might be due to circumstances like they're upset at themselves, so they are more likely to do so. This could be, like the people in high school that become bullies, right? A lot of the times the people that are bullies are just insecure. They're insecure. They have something going on that makes them act out. Could be their parents are getting divorced, etc. And this can apply to other things here like unemployment, poverty. Sometimes genetics can play into it. Just personality disorders sometimes can be, genetic. People that are narcissists or people that are antisocial or borderline might be more likely to kind of pass on or do some of these things. Even if they might not realize it, it can lead to abuse. So some common statistics, typically women are going to be the people that are going to be most abused. And when it comes to the victim, typically they're going to have low self-esteem and they might even take the blame for being abused. Like they might actually think that this is my fault. Um, which is a common reason, a common reason for why people might not leave a relationship. They might be gaslit into thinking it's their fault, and they want to make things better, um, or because of fear. That's actually going to be one of the number one reasons that they stay is because of fear of retaliation. They're afraid that their partner will kill them. So the victim can have feelings of guilt, anger, fear. I'm not sure what that is, but and fear. Um, the abuser typically going to be a man. They typically have low self-esteem, so like I mentioned, they want power over their partner. They might be possessive, they might be jealous. Now, when it comes to the cycle of battering, again, Don't have to fully memorize it, but just be able to recognize it. So the typical progression is you have something that builds tension. This is similar also to the uh, cycle of assault slash crises that we talked about. There's going to be something that causes some sort of tension, and in this case, the abuser might be easily provocated, so any little thing could happen. At this point, it might just end at this stage. It might be like something that gets them angry, they lash out, and then they're done. But if it continues to build up, this could lead to the next step. Something that's worth noting that you might see on like a Kaplan would be that a way the woman or the person being abused, in this case, though, very typically to be a woman, so that's just kind of like the default here. But whoever's being abused might preemptively just already be complying with everything they say because they know that they could escalate. So it could lead to kind of this person who is easy to anger, manipulative, and someone that is essentially just kind of enabling them to some degree. Not to say it's their fault, but it gets to that point because for their own self-preservation, just they know that's one way they can do to prevent themselves from escalating, prevent the person from escalating. So following that point would be the battering incident. So this is when the actual assault happens, the actual physical harm happens. And during this phase, the person that's, the batterer, the abuser can justify it to themselves. And however, because this person doesn't blame themselves, it gets to a point where they justify it. He's like, they might go to the points where they're like, you made me do this. It's actually your fault. You brought me to this point. I wouldn't have done that if you didn't do it. It was your fault. So that's where some of the gaslighting comes in. Following that, there's like they call it the honeymoon phase. It's also called like undoing in terms of like the coping skill, quote unquote. In which case they did the assault and now it's like, oh, but I love you. You're the best. I'm gonna buy you flowers. And it kind of is kind of manipulative in the sense, or it is manipulative because it's kind of like, oh, I'm so sorry, but I still love you. Sorry, it's you made me act up like that, but you learned your lesson, and as long as you don't do it again. So again, just gaslighting, and this is you can expect this to be a question. I think is going to be like, why do people choose not to leave um, abusive relationships? And it's largely due to a fear of retaliation. Outside of just like straight up being gaslit into thinking that it's not their fault, it's your fault. It's going to be the fear of dying when they try to leave, being murdered. So yeah, any questions on anything so far, either crises or human abuse? So the main thing is just kind of getting a general understanding of kind of the typical escalation of it.
Diego,
Uh-huh.
I don't know if you said it because I came in a little late. Isn't there phases of the crisis? Is there certain phases like, or did you already mention that? Sorry.
Yeah, I kind of have it here. I don't have it maybe in the exact same way that the book has it.
Oh, okay.
But it's the same typical
Oh,
thing.
I see.
And you're
Okay.
not gonna remember, it's not gonna be like what's phase two of
Oh,
crises. I don't, it's just gonna you just kind of have to know the general idea. So
okay.
like,
Thank you.
yeah. So something triggers, something makes it worse, crisis hits, de-escalation, full resolution. And you can see it to some degree here with the battering. You can see the trigger plus escalation. It could end there and it's done, or it goes into the crises, which is the acute battering, and then after that, it goes to the honeymoon phase, which is kind of where that gaslighting, manipulation comes in. So now moving on to oh, David, you have a question?
Yes, I had a quick. When you took this part, like the week 5, would it be safe to say that just be able to recognize the type of abuse, and then like giving them information of like who to call and like therapeutic communication. Is that
Yeah,
like the best way to go about this test?
I think so, yes. So for the most part, these again don't have to hard memorize these, just kind of be able to recognize some of this. And a lot of the time, what is the number one thing you do? If it's something that is abusive or could be considered you report to the police. So if you suspect abuse, and we're all mandated reporters, so if we suspect abuse of whatever kind, elder abuse, child abuse, it's your job to report it to the police. And we'll go over that one a little bit down when we talk about child abuse, but it's your job to report it to the police. But at the same time, you want to also, help with their feelings, because at the end of the day, they need support. They need emotional support, and that's going to be the number one thing. It's not really going to be like, for example, if you had a patient that came in and they were sexually assaulted, um, it's the number one priority is going to be calling the police, reporting it, and then helping them with their emotional aspect of it. You're not going to just say, "Oh, you got assaulted. Well, this is what you got to do. These are the 3 steps that you got to do," because it comes off as very blunt, not taking their emotions into account, and what they want is to feel heard and to feel supported. So, you're gonna eventually go over like the steps that are gonna happen, the logical steps that come next, but you're gonna focus on their emotions first and have them talk about it, vent about it, because that's genuinely how you prevent a crisis from occurring. Some people do better with firmness, and now I'm kind of shifting back to general crises, like a patient on the psych ward. Some patients might actually do better with being firm and direct from the very beginning, but to some people, that could just make them escalate. It might actually make things a lot worse. So, just have to, this is all comes down to just knowing the kind of patient, or just knowing, um, or I guess if whenever you're in doubt, you can just escalate your own firmness. So you could try the soft redirection, and then when it's not working, that's when you escalate over to a more firm direct, like, I'm telling you not to do this, you need to go back to your room. Versus like, hey, I know it's really upsetting. Like sometimes you can start with that, and if that doesn't work, you just go to the next step. That way you can prevent from unneeded escalation, and um, just because you started firm instead of otherwise. But typically, you want to start with the emotional side effect, especially if it's comes to abuse. But yeah, so then moving on to child abuse. So this is something that definitely you're gonna want to really be able to recognize the some of the signs and symptoms, the signs of abuse from the victim. Don't have to, again, don't have to like hard memorize everything. Just be able to recognize it. Be like, yep, that sounds like child abuse. Because you're not gonna get you're not gonna get a fill in the blank list all signs and symptoms of abuse, right? You're just gonna get maybe select all that apply or something. But typical ones: unexplained bruising, black eyes, broken bones, burns. Um, they don't want to go home. They might they call it shrinking around adults, so they might kind of just like not want to talk to you. They kind of back away from adults. Of course, they say like a sign that someone's the sign that somebody is possibly like antisocial personality disorder, or they call it a psychopath, is that they abuse animals or pets. And again, this is whole cycle of abuse. So if they're being abused, they might abuse animals or pets just as a kind of like you kind of say it's like a coping skill. Not a good one, but it's a good coping skill slash they're kind of following their model, their role model, which is their parents that are being abusive. So they start doing it too. Some signs from the abuser would be giving you a very unconvincing explanation for why the child's injured. So even if it is theoretically possible, if you do suspect that there is abuse, it is your job to report it. But yeah, they might describe the child as being evil or try to justify, like, hey, this child is unhinged. They're demonic. They just run around, do this, have no concern for anything. You might see that they're very, very harsh with them. They themselves could have history of abuse as a child. But yeah, this is for like physical abuse. Emotional abuse. The child might have extreme changes in behavior. They might be very demanding. They might be very passive, just allow things to happen to them. They're too compliant. They just do everything they're told, only what they're told. Um, might be very aggressive. They might be someone that has attempted suicide. They feel like they're not close to their parents, and they might even be delayed, have some physical or emotional development. They haven't fully reached their what the Maslow's or Piaget um from when you guys did pediatrics. And some signs from the abuser, they might constantly berate, blame the child. They're not really very concerned with it. Not really concerned too much for the child. Physical and emotional neglect. Emotional abuse and emotional neglect can be pretty similar looking. Child might be absent from school. They could be begging or stealing food or money because they're not getting any food or money for themselves. They might be lacking in some of their health care. They might not be vaccinated. They might not have glasses when they need glasses. They might have rotten teeth and there's nothing being done for it. They might be, uh, might have dirty clothing. They might be odorous. They might smell like urine, especially like a young child. Like they just smell like urine all the time. Parents don't care. They just ignore it. They're like, whatever. Uh, they could be abusing drugs, alcohol. They don't have anyone. They tell you that they don't have anyone to come home to. And the abuser in this case is completely apathetic. Like they don't even acknowledge their children at this point. They themselves could also just be abusing drugs or alcohol. If anyone's seen Breaking Bad, that one episode where, Jesse is trying to get his money from those people and they have like that one child that's completely neglected. Their parents are just unconscious doing drugs, whatever. Yeah, the ATM. Yeah, yeah, yeah. That's full on like neglect. That child was dirty clothing, didn't have food. Yeah. Um, and then, emotional abuse is also and neglect could also lead to personality disorders down the line. Could lead to, like the narcissistic personality disorder, could lead to like the borderline personality disorder. And, it is partially genetic as well, but it's all a combination of nature versus nurture. And then sexual abuse. This one for sure, I would expect a question on this. So some signs could be a UTI, definitely an STI, right? But UTI can be a common one that could happen. Sometimes girls can just get UTIs because, it's easier for them to get UTIs, but also, if they're like at the age where they wipe themselves and clean themselves, they could just naturally get an UTI. But if it's happening very often, or maybe they're too young for that to be the case, it might be a bit more suspicious. Pregnancy could be, they were assaulted. Regressive behavior. So at like a 9-year-old is starting to wet the bed could be a sign of regressive behavior or acting more childlike because they're kind of like regressing to a state where things were more comfortable. Unusual sexual knowledge, running away from home, And this one, becoming quickly attached to strangers or new adults in their environment. They just cling on to the adult. They might even try to make sexual advances to the adult because in their head, that's what they know. They're emulating what their parents are doing to them or whoever, their uncle, their brother, whatever, or whoever's doing it. And some of these things would be from the abuser side is being inappropriate, having, very weird, inappropriate relationship with the child, being very controlling or protective of the child, being secretive, favoritism, giving them gifts all the time. So again, um, your goal is to report it and and I know I mentioned like emotional stuff that does come in. That's going to come in before kind of like the logical part of it, giving them logical next steps. But even before that is actually going to come like the medical needs and safety. So calling the police, getting them to a room to be, assessed, gather evidence, whatever. Make sure that they are physically safe, physically stable is always going to come before psych. Um, just because the psych stuff it's gonna be it's not good but it's not gonna kill you directly at least, so keeping them safe, keeping them physically stable. So for example, if someone was battered, they were beat up, bruised all over, you're gonna make sure that they're not like internally bleeding or they didn't sustain any hit to the head before all the stuff needs to go down, just because in that case you do have to make sure that they're gonna live to be able to be emotionally supported. Something that Miss Gonzalez mentioned to our class, I'm not sure because I think you guys didn't really have too many. Actually, no, I think you guys did have a lot of in-person classes, right? It's just that a lot of your lectures were all like asynchronous, but you did like in-person assignments or something like that. Is that correct or no?
You said in-person assignments?
Yeah, did you guys have like a lot of in-person lectures or was it just like in-person to
Oh,
do
yeah.
work?
Oh, no, like David just said, 50-50.
50/50. Okay, gotcha. Yeah, this is something she said to us is that, that when it comes to like abuse, whoever is the caregiver has the right to technically deny pictures of the children being taken of like whatever bruising, whatever. So you kind of have to be careful and follow your own policies. You have to make sure things are very properly documented so that in a court of law, it's undeniable that there's abuse happening, even without pictures, or even like if you can find a way to get the pictures taken without with their permission. You don't have to be like, hey, we suspect that there's abuse. You'd be like, hey, we just want some pictures for our records. Just taking pictures for our records. So if they get another bruise later, we know that it didn't come. We know that it came from us or something. Something that gets them to be like, yeah, sure. No, you're not technically lying. At the end of the day, you're doing this because, you suspect abuse and you want to be able to have proof so that you can escalate it to the proper channels. So further down here, I just have the that homework assignment that you guys had to do with the answers here. Uh, all I'll say is that you should review these. You might there might be familiar questions on your test from here potentially. Maybe not like some of the specific statistics, but like some of the general ideas you might see here. So yeah, I would definitely go through some of these questions again and just review it for the final, more so than the Kaplan. The Kaplan is gonna have a bunch of random stuff. And honestly, for the Kaplan, just answer whatever you think makes the most sense. Because sometimes you'll have questions about like how do you approach the situation, and it's meant to be about like therapeutic communication and It's just kind of like whatever sounds right to you. Although granted, you might come across one of those questions where like this is technically the way you're supposed to approach it, but in real life, no, you're not going to approach it this way. So an example that I could give would be um, maybe I guess I feel like in class you guys maybe were told like if somebody is acting delusional or they're confused, you want to redirect them. Uh, and maybe it just depends on interpretation of it. Like for example, during that simulation group, when it came to that older lady that was almost falling off the bed, she's confused. She's very confused. She thinks she's gonna go meet up with her husband, to go to a party or something like that. But her husband's been dead. In this case, redirection does not mean that you're gonna tell her that her husband's dead because there's no point. She's gonna be upset. She's gonna go through like a little mini crisis. She's gonna forget about it because she's very confused, very has dementia, she's gonna forget about it. So in this case, redirection does not mean like um kind of like percent reality. It's more like redirecting her away from what like she's focused in on. So instead of saying like, your husband's oh, you can't actually go with your husband because he's dead. uh you would say like like oh, okay, yeah, we'll get to that maybe, but right now we're gonna do this, or um yeah, let's talk about that actually, like how it like what's your husband like, what kind of dress are you planning on getting, you can talk to me about it while we're doing this, like well I'm prepping your meds, or tell me about where you're planning on going, tell me about like what's your favorite thing you've done with your husband, or tell me about your son. Just that's that kind of redirection. Um, or if you have a patient that is having delusions and stuff, you can redirect them to like I would not recommend trying to like tell them like no, that's not true, that's not happening. I would just recommend to just kind of redirect them back to the room or redirect them to be focused on something else without directly challenging it, because a lot of the time that's just gonna make things worse. It's gonna have them escalate. Uh, you're just gonna, and at the end of the day, a lot of times they're not able to, like, it's not gonna actually do anything for them. I think I would save that for like a therapist. I've had a patient at La Casa who this person was like under the belief that they were Bruce Lee. They thought they were Bruce Lee. And, if you try to challenge that, they wouldn't escalate, but it'd be like, hey, you're Bruce Lee. Oh yeah, you were in that one movie, but I thought you were 20. So how were you able to be in that movie if that movie came out 30 years ago, or at this point probably like 50 years ago, like 50 years ago, and you're only 20. And then he'll actually just make more del in his head, he makes more delusions to justify it. So he was telling me, it's like, oh, actually, I've been alive for hundreds of years. Uh, it's like hundreds of years, and it's like, yeah. In fact, I fought zombies. I saved the world from zombies, actually. So you're welcome. Like I had a gun, I was killing all the zombies, and I'm like, oh, really? There's zombies. So like, where are all the zombies at? And he's like, well, you don't have to worry about that. I already got them. So like, like if you try to redirect them there, like he just kept making up more delusions to justify the rest of his delusions. So there's really no point. So when it comes to when it comes to redirection, it's really just moving away from what they're focused on rather than fully reality setting. You can do reality setting depending on the situation, but it's a judgment call kind of thing. Rather than like all the time you do it. Especially with dementia people, that you might just have to kind of you might even go with their delusions, honestly. If they're saying like, hey, it's raining outside and it's bright and sunny, you'd be like, oh yeah, it must be really cold out there, huh? So I guess it's good that we're in here, or whatever, right? You try to reality set too often, it might just make them upset. So that's something to kind of keep in mind there. And again, always focus on like the emotional side of it when it comes to therapeutic. Therapeutic communication is going to be number one thing rather than like just the pure blunt logic part of it. So it might have some answer choices where one of them makes the logical sense. This is like the logical next step to what we're doing, but it doesn't make sense to bring that up. It comes off as cold and blunt, which is not really what they need. There are instances where you definitely want to be reality setting and firm, but that would be something to do more with like people with personality disorders. So like a borderline or a narcissistic patient that is manipulative and kind of passing through boundaries, like trying to break boundaries. They're trying to get away with certain things. That's when you can try to be reality setting, and that's when you can try to be firm because that's what you're supposed to do. You want to be firm and consistent. So firm and consistent with borderline people, narcissists, manipulative people. Um, I had a patient that he was definitely delusional. He thought he was God. He was manic, very manic. So it was one of like those grandiose delusions. So he thought he was God. He thought he was the best. He was going around just very manic, never sleeping, refuses to take meds. You ask him how he's doing, how's your meds been going? He's like, perfect. I wouldn't do a thing. It's perfect. But he would be refusing meds and uh, clearly not improving, but refusing to change his medications or approve or disprove, not approving any change in their dosing or anything, not approving new meds being added on. So he was a very big guy, and he was also very muscular, and he would use that to his advantage. So he would try to get away with things. Like he would be like, "Hey, it's 3 a.m. I want a smoke break right now," because he's like, he knows that he's a big guy. He knows that if he were to fight, we would either, it would be a very hard time for us, or if he would even threaten to AMA, which at a lock facility, obviously you can't do. But at Ocean View, because it's voluntary, um, you can leave. But if it's against medical advice, we do a pet call. We get a pet clinician to come in and evaluate the person. And this person had been actually the pet was called on him before, but he was able to kind of act like he was super calm and like, no, nothing's wrong. Nah, I want to stay. No, I don't. No, I'm good. And he was able to not meet criteria for that. So he knew that he's like, he in his head he could get away with it. So he would be like, "Nah, I want to leave. I don't feel safe now." So he knew that it would be like it'd be trouble it'd be like you're gonna have to call pet on me. You're gonna have to call the clinician, and they're gonna get here at a very bad time where we're all busy, and you're not gonna want to deal. You're not gonna want to deal with that. You're not gonna want to deal with me being aggressive. So you're gonna give that to me. Um, and I was actually charge nurse this day. So and I knew that this guy needed to be out, and we had like a majority male staff actually. So I was just like, let's just do it. Let's just get him out of here. He's like, I want an AMA, and I'm like, that's cool, man. Uh, that's fine with me. That's cool. That's your choice. We can go ahead and do that. He walked me to his room, and then he was like, it's like, well, I don't feel safe, but if I had a cigarette, I might feel safe, you know? And I'm like, nah, it's okay. You want to leave, it's fine. We're gonna call the evaluator and we'll see where we can do because yeah, we're not gonna let you go down for smoke. And if that's what you're gonna decide is the breaking point to make you want to leave, that's fine. And we called the evaluator. They came like an hour and a half later, but he was still kind of agitated and he tried his best to pretend like he wasn't. Like he tried his best to pretend like he was like, oh, I'm so sleepy, I can't talk to you. To try to be like, how could I be agitated and how could I be causing issues when I'm so sleepy? And then that whole thing turned into that whole thing uh turned into like a takedown situation. He needed to be restrained by like 9 people to get put on the gurney to go to College Medical Center to be given a shot immediately as soon as he gets there. Um, but in this case, it's just like being firm was the like this person needed to be firm because he was being manipulative. He was needed reality setting. This person needed a higher level of care, 100%. He needed to be, this guy probably needed to be put on a 5250. So after the 3 days are done, put on a 14-day hold and probably needed to, if he was not complying, go through a Reese hearing to be, um, so that we could force him to take meds. Um, and in this case, it would be like Cyprexa shots, so shots of olanzapine. So if he refuses his PO meds, he just gets a shot of Cyprexa. And sometimes it can be tough because sometimes the patients they'll just they'll want you to give them they'll want you to give them the shot because it's it's a it can help you relax. The antipsychotic can just kind of put you in like a relaxed state. Some patients might want the shot because they want to feel almost like that high. So sometimes you'll be like, you know what, I'm not giving you the shot because like you're not taking your PO meds. You want the shot, you're not getting the shot. So sometimes that helps them. It's like, well, you're not getting the shot. You're actually just going to be put on isolation. You're going to go to the seclusion room. So whatever it is, like, that's just kind of like that higher level of care. But other patients like that older lady in that simulation lab just needed to be redirected to a different focus, be put in a happy place. Okay. Yeah. Any questions on anything talked about so far? Okay. If not, I will stop the recording.